introduction. Good evening, everyone. Today, I would like to invite Dr. M.V. Shekhar Reddy sir and Dr. Rajesh M. sir for their wonderful presentations. I would like to start with Dr. M.V. Shekhar Reddy sir's presentation first. Sir?
Yeah, good evening all. Am I allowed to share the screen?
Yeah. Shekhar, just introduce yourself.
Yeah, I do it. Good evening all. At the outset, I would like to thank Endocrine Society of India and Endocrine Society of India for this opportunity. And I would like to thank KV sir, Maithili ma'am, Ram Mohan sir for this opportunity. Today, I'll be presenting a case of PCOS, which we routinely see in our day-to-day practice. Now, coming to the case, a 22-year-old female presented with a chief complaint of irregular cycles for the last 4 years and hair growth over the face and back for the last 3.5 years. Now, coming to the history of present illness, patient was apparently all right for 4 years from when she started having irregular menstrual cycles once in 2 to 3 months for the initial first year, followed by cycle once every 4 months for the last 3 years, and the cycles were lasting for 2 days, scanty flow, and no intermenstrual bleeding, which is suggestive of oligomenorrhea, which implies there are less than 8 cycles in a year. And there is also history of hair growth, which was noticed for the last 3.5 years, initially over the chin and upper lip, which progressively increased in these regions and later developed over the lower back, inner thigh, and over the abdomen, and acne over the face for the last 3 years. And she was sedentary for the last 4 years with history of progressive weight gain of 10 to 12 kgs and soaring during the night and lack of refreshing sleep for the last 3 years. And there is no history of galactorrhea, abdominal pain, any difficulty in climbing stairs on any marks of the abdomen, and no history of any facial puffiness, cold intolerance, weakness, and constipation. And there is no significant past history, but there is no history of any chronic illness, but there is history of use of progesterone intermittently for getting withdrawal bleed 2 to 3 times in a year for the last 2 years, and history of use of topical cream for acne. And coming to the families is very important in a case of PCOS. She is a product of non-consanguineous marriage, second in birth order, with history of similar complaints both in the mother and her elder sibling, with history of oligomenorrhea and hair growth in both the mother and the elder sister. And both the parents are having type 2 diabetes, and mother and maternal grandmother are obese. And coming to the examination from head to toe, there is a temporal hair recession and acne grade 2 over the forehead and both the cheeks. And there is double chin and acanthosis nigricans grade 3, where black velvety skin texture is present just crossing the lateral fold of the neck, not visible from the front. And the hair growth is seen over the upper lips, chin, back, inner thighs, and abdomen is thick and coarse. And the modified Ferriman Galvez score is 80, which is suggestive of a moderate hirsutism. And there are no features of defeminization like breast atrophy, and there is no stria, and there is no clitoromegaly. And coming to the vitals, pulse rate is 92 per minute, and blood pressure is in the right arm sitting position, it is 130 80 mm of mercury, and the waist hip ratio is 0.92, and the BMI is 32.88, which is class 2 obesity. You can see this elevated waist hip ratio and obese is suggestive of android obesity, which is classically seen in PCOS, and systemic examination is unremarkable. Now, to summarize the case from history and examination, here is a 22-year-old obese female presented with oligomenorrhea, which is suggestive of anovulatory cycles, and features like hirsutism, acne, and temporal hair recession is suggestive of hyperandrogenism. This oligomenorrhea and hyperandrogenism together, we can come to a clinical diagnosis of PCOS. Now coming to the other, what are the other possibilities which we need to think? We always need to rule out secondary causes of PCOS. Particularly in this case, I would like to consider Cushing syndrome because of anomaly state and as well as hyperandrogenic features like acne and hirsutism. But there are many important differentials which can be considered routinely in all cases of PCOD that include idiopathic hirsutism, in which the patient will be having regular cycles and the testosterone levels will be normal, but the patient will be having hirsutism. And this is idiopathic hirsutism, which is usually a diagnosis of exclusion. After ruling all the causes, then hyperprolactinemia. In hyperprolactinemia, there can be luteal phase defect leading to anovulatory cycles, and there can be mild androgen excess. Similar thing can happen in hypothyroidism. Then non-classic congenital adrenal hyperplasia. Usually there will be a history of consanguineous marriage with parents, and the female may be short, and there is history of peripubertal virilization and oligomenorrhea, and there can be clitoromegaly also. And tumors are suspected only when there is rapid onset of virilization, and the patient will develop features of virilization like rapid growth of hair and breast atrophy, and the clitoromegaly will develop over a short duration of time. Then only we need to suspect adrenal tumors. Then glucocorticoid resistance syndrome. In this glucocorticoid resistance syndrome, the diurnal rhythm of cortisol is maintained. The patient will not be having any stigmata of Cushing's, but the cortisol levels and ACTH levels will be elevated. So these are all the important differentials which should be considered in case of PCOS. Now coming to the investigation part, we need to do hormone evaluation in the follicular phase, and we have done in this case LH is 6, FSH is 4, testosterone is 92 nanogram per dl, which is elevated, prolactin is mildly elevated, and 17 hydroxyprogesterone is 0.9 nanogram per ml, so it's normal. So non-class CH can be ruled out. DH is within the normal limits, and overnight dexamethasone suppression test is done on another day, where 1 milligram of dexamethasone is given at 11 p.m. and cortisol has been taken at 8 o'clock, which is 1.1 microgram per deciliter. So it is less than 1.8. So Cushing syndrome is ruled out in this case, and TSH is 5.5. Now my query is, should we do AMH levels in all cases of PCOS? If I can take the opinion of the experts, Dr. Maithili ma'am or Dr. Tejal ma'am, can you comment on this?
Yeah, just a few words.
No.
I really am happy and proud to have Dr. Tejal with us. Dr. Tejal is an eminent endocrinologist and she is an expert, national expert on PCOS. She has several publications on PCOS in both national and international journals. Tejal, over to you for your comments on the different hormone tests that are done in this case and the query raised by Dr. Shekhar also.
Sure, ma'am. Thank you very much for the kind introduction. So I agree with most of what you said, Dr. Shekhar Reddy. Sometimes the LH, FSH, usually I don't do it. If I have to conserve money and if it's somebody who's from not a very affording background, what we sometimes fail to realize as treating clinicians is all these tests together sometimes come as close to 10,000 rupees, so may not be accessible to all. So if I had to choose, then testosterone, prolactin, TSH, I would do for sure. And then some of the other tests I would do depending upon the clinical stigmata, which I'm sure all of you will agree. And of course, if it's possible, we do all of these. The AMH, the politically correct answer is that AMH is not recommended as a routine test for people with PCOS and is not required for the diagnosis. But sometimes, maybe out of about the 30, 40 women who present with a PCOS-like picture, sometimes ready premature ovarian insufficiency is also something that I have diagnosed. And sometimes if I am in a dilemma, I'm not sure, then an FSH and AMH is something that I would add on. So I don't do the traditional LH-FSH ratio. I don't think it contributes much. But sometimes if POI seems to be on the cards, depending upon the history, the periods are becoming more and more delayed, less and less flow, not very obese, lean PCOS, lean suspected PCOS, then I would probably sometimes consider an AMH, but not as a routine for all patients.
Okay.
Tejal, the message I got is to differentiate a lean PCOS from a hypothalamic, from a POI. I think you were saying that FSH and AMH are really helpful tests, right?
So AMH in hypothalamic amenorrhea, no, but yes, FSH in
Yes.
hypothalamic amenorrhea, definitely. AMH, if I'm suspecting POI, then sometimes, yes, I would do the test. Of
Yeah.
course, it has its own problems, the AMH, which I'm sure Dr. Reddy will elaborate on.
Thank you.
Thank you. So this is what the latest recommendations from 2023 International Evidence Guidelines on PCOS tell. Here you can see a very strong recommendation with good quality of evidence, which shows serum AMH should only be used in accordance with the diagnostic algorithm. Especially, as Rachel Madam told, in patients with irregular menstrual cycles and hyperandrogenism, an AMH level is definitely not necessary for diagnosis of PCOS. And another problem with AMH is it's not widely available also. We also need a SS-specific cutoffs and population-specific cutoffs also. So it's not routinely done. Next, coming to the metabolic evaluation in this patient, we definitely need to do a 75 grams oral glucose tolerance test. In this patient, the fasting plasma glucose is 106 and 2 hours plasma glucose following 75 grams glucose load is 154. And the total cholesterol is mildly elevated. HDL is 41 and LDL is 149. Triglycerides is 184 and SGOT and SGPT are normal. Now coming to the imaging, ultrasound abdomen is usually done, but if the patient agrees, transvaginal ultrasonography is a better modality, which is why I'll be discussing further. So the patient has, I'll be discussing only the positive findings. She has stable fatty liver, and both ovaries are enlarged in size with volume more than 10 centimeters, and there are multiple follicles, each measuring 2 to 9 and distributed around the periphery, and there is increased ecogensity in the center of ovary, which is suggestive of hyperechoic stroma. Now, again, routine clinical practice, I always get it out. Do we need USG in all cases? Actually, can any one of
Yeah.
you?
Chetan, I'm really happy you have raised questions on AMH and ultrasound. So this is a case where you have hyperandrogenism clinically, and then there is a anovulatory dysfunction. So what we really say is that ultrasound is not required in all cases.
No.
Over to you, Tejal, for your comments.
Yeah, completely agree. And also bring up the point that many times the diagnosis is made and then patients continue to do a ultrasound even for follow-up and say, oh, there were cysts in the ovary, but they're not there anymore. So I think from both of those perspectives, one is not necessary for diagnosis, especially if it's pretty clear-cut. And unless there are some other symptoms like there is dysmenorrhea, if there is coexisting endometriosis or adenomyosis, clinically only then we would do. And also that we don't need to do it.
Yes, ma'am. The guidelines also recommend the same. Ultrasound is not required in patients having both the features like hyperandrogenism and ovulatory dysfunction, but it's usually indicated only when one diagnostic feature of PCOS is present. And mainly, we have to rely on the follicular count, which clearly suggests the number of follicles in the ovary, which is usually it's difficult on a transabdominal ultrasound. But in a transvaginal sonography, we can get number of follicles per ovary. Whereas only in transabdominal, you can get follicular number per cross section can be given, and ovarian volume can also be given. The 2023 guidelines tells an evidence-based recommendation that only in the presence of one diagnostic criteria only, then you can do ultrasound. Otherwise, it's not. But when we are doing ultrasound, we need to get this information. Follicular number per cross section and ovarian volume is must in transabdominal ultrasonography. Whereas in transvaginal sonography, you can also get follicular number per ovary. Now, in this particular case, after getting all this information, we can tell the diagnosis primary PCOS with prediabetes, and also this patient is at high risk of obstructive sleep apnea. Now, I'll have a brief discussion about the diagnostic criteria, how I came to the diagnosis of primary PCOS. First, it was in 1990, the NIH has included two things, that is hyperandrogenism and hyperandrogenemia, oligoanomalation. At the same time, we need to exclude the other disorders which I have mentioned in the differential diagnosis. To this, the Rotterdam criteria came in 2003, which added ultrasonography to see any PCOS morphology. Then came the Androgen Access Society criteria 2006, which included hyperandrogenism features, which is clinical or biochemical, or ovarian dysfunction with oligoanomalation and polycystic ovaries. And at the same time, we need to exclude the other causes of androgen excess or related disorders. Now, coming to the challenges what we face in the clinical practice during the management. Now, we all know that the management of PCOS be according to the concerns of the patient. Now, I would like to take the expert opinion. How do we manage the weight of this patient as she is obese? Dr. Maithili ma'am.
So I think this woman's BMI is 2.8. So
Yes,
it is a class 2 obesity, or maybe we can use the other classifications of obesity. Definitely she needs to, weight loss is the cornerstone in the management of this particular case. It really makes a lot of difference. Her cycles will improve, and then her hyperandrogenism will come down. I think we need to sit with her and then emphasize the benefits of weight loss for her concerns. Dr. Tejal?
So the question is regarding the weight. So one of the things that I find in my practice is that we tell women to lose weight, but we often don't share with them the tools of how they can lose weight. So that's, I think, one need gap that we have in our practice. So we send them to the nutritionist. The nutritionist tells them some diet, and then they go home and they're expected to just follow that diet. So what I feel is one of the need gaps we have is a systematic lifestyle support program that women with PCOS need to have, where there is ongoing support. There is somebody who's holding their hand, who's helping them along the journey. So I do prefer some lifestyle programs, some of which I know very well that they've been designed by good people and ethical and good. But I think that helps a lot. So if they have a clear nutrition plan, a clear exercise plan, and stress is taken care of, sleep is taken care of, and there is a hand holding or somebody who supports them through the journey. When all of these things come together, only then the weight loss happens. So doing only weight, only exercise, only stress and sleep is not sufficient, and everything needs to come together. Different women have different personalities. Some are very self-motivated and are able to do all of these things on their own. That's great. If they're not, then providing them with an alternate where somebody would be holding their hand and helping them on their journey, I often see is conducive to better weight loss.
So to
Exactly,
what
ma'am.
Dr. Tejal mentioned, we have the SMART, specific, measurable, achievable. So that
Yes.
is what I think you were mentioning.
Yes.
Mainly diet and exercise should go hand in hand. At least if there is at least 5% of weight loss, then the patient can have benefits. They can have.
There is one
like-
question from Shekhar. There is one question from Kanav. How much weight loss should be lost over how much time?
Weight loss, usually we plan at least 500 kilocalories deficit
So,
week, so that
so
at
to
least-
say that a particular program is beneficial, or as Dr. Tejal mentioned, you need at least 5% weight loss. Shekhar was
Yes, ma'am.
mentioning at least 5% of weight loss. So when you start with a particular program, you say that over a period of 3 months, you expect at least 5% weight loss. And the benefits of weight loss, say for diabetes remission, is 5 to 10%. Then for weight reduction and then for correction of other parameters, it needs much more. So it is on an average between 5 to 15% of weight loss really shows benefits. So you start with a particular program. Over 3 months, you again measure whether the program has produced a particular weight loss of at least 5%. It could be lifestyle, it could be pharmacotherapy, or it could be other options.
Next, Tejal ma'am, how would you deal with the irregular cycles and hirsutism in this particular case?
I feel that so what I do in my practice is that I make things very individualized or customized. So when we see somebody with hirsutism, often we assume that it's important to them, or we assume that it's not important to them. So what I do is ask the patient how they feel about the hirsutism. Is it something which impacts their quality of life? What do they do to take care of it? However they take care of it, is it satisfactory? So I've had a range of responses. There are some young girls who say it doesn't bother me and I don't even want to do anything about it. On the other hand, we have women who have very little hair but are extremely distressed about it. So I think patient important hirsutism is a concept when how important is it to the person who is having it and then what they want. Usually, if somebody has a combination of oligomenorrhea and hirsutism, then estrogen progesterone pills along with maybe spironolactone works really well. However, again, there are a lot of different people and they have a lot of sometimes negative opinions about hormonal medications. I try not to use the word oral contraceptives. I try to use the word hormonal pills because oral contraceptive itself is a word which carries a lot of stigma, especially in young women like these who may or may not be sexually active. So if oligomenorrhea and hirsutism both are is what the patient is having, and the hirsutism is something that she needs treatment for, and it is affecting her health, then I would consider hormonal pills, maybe for about 6 months. And if the response is poor, I would consider adding on spironolactone. And also, depending upon whether how severely it affects her, a lot of times closer to marriage, they also like to add on laser, which helps to remove the hair, which has already become hard before. And then the hormonal pill, new hair, depending on that. But there are many women who are absolutely terrified of hormonal pills. There's a lot of negative information about it out there. And in those cases, for the irregular cycles, I'd probably give like a cyclical progesterone withdrawal bleed, maybe every 30 to 45 days, and then treat the hirsutism separately with maybe laser, depending on whether they're comfortable with it or not.
Tejal, what about metformin for her irregular cycles in this case? Would you prefer or not?
I have mixed feelings about metformin. So maybe in young girls who have only oligomenorrhea, then maybe for menstrual cyclicity, I would offer metformin. Maybe if they have impaired glucose tolerance or impaired fasting glucose, I would offer metformin, but I don't usually offer it. I do not find much of an impact on the hirsutism, the hyperandrogenism part, especially with metformin. Yeah.
Ma'am, how long do you give recipients? Means majority of them will be telling, will be asking us how long do we need to use?
Yeah, you're absolutely right.
Shikha.
Sorry.
At least 6 months, right?
Yes, ma'am.
Yeah, I think full disclosure is what we should offer our patients. So we tell them that, yes, we would like to give it to you for about 6 months to 8 months, and we add on laser along with that, and we see how the response is. But we all understand that PCOS is a chronic condition and it's not going away anywhere. And often women do require prolonged hormonal pills as well as spironolactone. So I tell them that depending upon how they respond, how well they tolerate the medications, it could be required for a longer period of time. Our job is to offer all choices with full disclosure of pros and cons. And then it is up to the patient to make the choice that they feel is appropriate for them. And many times, if you communicate like this, initially they may not be ready, but then they will try many alternate things and realize nothing else works and come back to you and say, you know what, doctor, I think I'm ready for this now. And maybe so it may take them a couple of months to come back, but then they often come back.
Yeah, that's what happens in our day-to-day practice. You're absolutely right.
Shekhar, there is one more question from Manisha.
Okay.
Ma'am, how to address hirsutism in PCOS with regular menstrual cycles?
So she's talking.
That is what
you
ma'am
get
has
hirsutism.
she has just discussed. She said you just take the patient's concerns about hirsutism, right, Tejal?
Depending on how it's affecting their quality of life, the severity of their hirsutism, or where they are in their career, or are they close to marriage. There are so many variables which decide whether or not they want treatment and then what is the options. With regular menstrual cycles, sometimes only laser may work, especially if the hormone levels are not very high. Maybe a trial of only laser can be tried. And if after that it doesn't get better, then you could consider low dose spironolactone. Many dermatologists give a small dose of spironolactone along with laser. But we all know that with spironolactone, sometimes there can be irregular periods, polymenorrhea, polymenorrhagia. And then if the hirsutism is very severe, in spite of regular cycles not responding to laser, we may need still to offer hormonal pills even in these young women.
Okay. Okay. Next, how would we consider the metabolic and cardiovascular risk in this particular case, ma'am? Mainly, ma'am.
So I think there are a good number of issues you have raised, Shekhar, in this particular case. Number one is her BMI. I think number two is her impaired glucose tolerance. Number three is most important. What you have raised is the obstructive sleep, possible obstructive sleep apnea, which we need to evaluate. And I think there is a little impaired glucose tolerance. There are so many metabolic and cardiovascular risks in this particular case. I think again we go back to lifestyle modification, weight reduction. Probably will definitely 5 to 10% of weight reduction. Her LDL also is high. Then her testosterone is high. So there are definitely we need to address the metabolic and cardiovascular risks. I think taking her weight and her obstructive sleep apnea, evaluating for OSA, then maybe weight reduction with metformin if she's not tolerating metformin. I think GLP-1 receptor agonists would help. There are a couple of articles of the efficacy of GLP-1 receptor agonists, but again, not universally accepted.
Yeah.
So these are my thoughts, and maybe we will ask Dr. Tejal her comments.
Tejal, ma'am.
Yeah. First of all, assessing the metabolic risk. So we make sure that not only at the time that the patient first sees us, but also as we continue to see them over the years, because the pre-diabetes can become diabetes anytime during the course of the journey. So I do have young 23, 24-year-olds who've gone from pre-diabetes to diabetes. So calculating the cardiovascular risk, assessing the metabolic risk, and depending on that, as ma'am said, absolutely lifestyle modifications. Metformin may help in this situation. GLP-1 analogs. So I have several patients who are on GLP analogs. They lose about 10 to 12 kilos of weight. The diabetes goes into remission. The hair is better and many of the symptoms improve. There's one more thing that I would like to bring up here. It may be unpopular, but many women with PCOS who are extremely overweight. So I get young girls who are 130, 140 kilos of weight. Now, in these women, the quantum of weight to be lost is very large. They need to lose 40, 50, 60 kilos of weight. In these patients, GLP-1 analogs are not really the first choice because they even give limited weight loss. Even with the newer double GIP GLP-1 agonist, weight loss will be about 20%, which is not much for somebody who weighs 140, 150 kilos. So I also offer bariatric surgery as one of the treatment options for women who've tried multiple cycles of diet, multiple cycles of exercise. They've done it every time, lost the weight, it's all come back. Then bariatric surgery is also one of the treatment options that is available to us, especially if the quantum of weight to be lost is larger. This often helps them, their diabetes and pre-diabetes to go into remission, their lipids come down, the HSCRP comes down, and all the cardiovascular profile and metabolic profile does it.
What is your experience, Tejal? Your experience with bariatric surgery is the women accept and are they comfortable post surgery in PCOS?
Yeah. So again, with every situation, there are a gamut of patients, right? So there are some patients, if you mention bariatric surgery, they will run screaming from the clinic and never come back. But that doesn't mean we don't offer it. But you will not believe the number of women who research bariatric surgery. The parents have researched it. They're mentally ready. And sometimes you're just waiting for the doctor to mention it and they are okay. So I recently had this experience where a young woman came, she was 148 kilos and she was about 5 feet 2 inches. So that's a huge amount of weight to be lost. She'd seen a physician who'd offered her GLP-1 analogs and everything. And the minute I opened my mouth and I said, bariatric surgery, you know what, doctor, we wanted to do surgery. We just wanted somebody to tell us that it's okay to do it. And we really want to go for surgery. And they were ready like this. I referred them to the surgeon. They took an appointment the next day and she will undergo surgery within. So our job, I feel, if I'm reiterating the same thing again and again, we offer choices. And then depending upon what they are comfortable and not comfortable with, they may or may not take it. I have many women who've undergone bariatric surgery at 130, 140 kilos. They're maintaining 75, 80, 82 kilos right now. They're cycling regularly. They've gone on to have pregnancies. A very good experience. Of course, the surgeon has to be good. So you need to collaborate with somebody who's really good. But yeah, a good experience.
Thank you.
Okay. Next, Maithili ma'am, you were telling about the obstructive sleep apnea. So should we evaluate for all PCOS patients for OSA or not?
So I think, Shekhar, you have to use the questionnaire first. And if really she satisfies the criteria for screening for OSA, she has to undergo screening for OSA. The reason is the bidirectional relationship between obesity, PCOS, and OSA by itself is an increased risk factor for cardiovascular events. So definitely she needs to be screened for OSA in this particular case.
Okay. Tejal ma'am, any thoughts? Any of your thoughts on OSA?
So this is one place where people, most of them do not like the CPAP machine, right? Most of them are unhappy with it. So I had a patient yesterday in the clinic said that it made my sleep worse after using the machine, right? Because it's uncomfortable. So I would focus on weight loss because I feel losing weight is probably the best way to ameliorate obstructive sleep apnea without going for something like invasive, like a machine or something like that. So maybe weight loss is what I would focus on. But as she said, I do have this top bang questionnaire, which is bookmarked on my computer screen in the clinic. So if I feel like somebody's talking about exhaustion, tiredness, daytime sleepiness, they don't feel fresh, then immediately it takes 2 minutes to run the questionnaire. And if you pick somebody up, then yes, focus more carefully, maybe on weight loss. And then, of course, refer to maybe a chest physician for a formal evaluation.
Yes.
Shekhar, there's one question from Dr. Kavya. Which do you prefer among obstructive and restrictive surgeries for those with young PCOS and obesity? Maybe Dr. Lance will take this. Obstructive and restrictive surgeries for those with young PCOS and obesity.
Oh, okay, I'm not sure what obstructive surgeries are. Are you talking about like maybe a balloon or something like that? And then we're talking about gastric bypass and sleeve gastrectomy. Unfortunately, so my best friend is a bariatric surgeon, so I'm not biased, but I do know the details of the bariatric surgery world very well. And she is my MBBS classmate. The obstructive surgeries are like using a medical treatment that until this balloon is in place, the weight will go away. The minute you remove the balloon, it's all going to come back. So it's not really a definitive way to lose weight. In Bombay, it's like a fashion that if somebody's going for a wedding, they get a balloon or they lose 10 kilos and then they take it out. It's actually things like that happen in our country at this time. So I'm not in favor of very keenly on the obstructive kind of balloon, etc. And usually a sleeve gastrectomy versus gastric bypass. How do you decide between the two? If diabetes is there, then a gastric bypass is a much better option because diabetes remission is much better with gastric bypass. If it's only weight and there is no diabetes, then maybe a sleeve gastrectomy. So the quantum of weight to be lost, whether how bad or good the metabolic features are, depending on that, you and the surgeon need to collaborate and figure out what is the best surgery for the patient.
Thank you.
A couple of minutes if anyone would like to add their comments or any questions from the audience.
Hi, madam.
Hi.
Good evening, madam.
Yeah, please ask. Please proceed.
Regarding the initial investigations, what are required for PCOS regarding the prolactin hormone evaluation? So the main role of prolactin, except from oligomenorrhea, there is no role of any prolactin value in deciding the hyperandrogenicity. Why? Because prolactin itself, elevation of prolactin causes hyperandrogenic symptoms. So since these obese and oligomenoric and clear-cut hyperandrogenic features are there, there's no point in doing prolactin because it adds up. There's no other additional feature of doing prolactin because even mild elevation of prolactin, they attribute it to hyperprolactinemia and they start using cabergoline. It is what we
Yeah,
observe in
Rakesh,
the reporting practice.
mild hyperprolactinemia, we do see in a good number of PCOS cases.
PCOS.
So because prolactinoma, presentation of prolactinoma is with oligomenorrhea, and because of the adrenal androgen, increase in adrenal androgens, they do have hyperandrogenism. So as a because it is a mimicker for PCOS, we do measure prolactin routinely in all cases. This is just an exclusion.
And one more thing, OCPs versus adrenalectomies. Most of the cases when we advise OCPs, they add to the weight gain and the hyperandrogenic resolution. Just the main purpose of our adding OCPs is giving time for the patient to adjust for weight loss. In the meantime, for addressing hyperandrogenemia. So, instead of OC pills, as madam discussed, spironolactone would be a better choice if they are not willing for any side effects of OC pills.
Yeah, Dr. Tejal mentioned this also. She said that spironolactone, she said, in fact, she voted for it. But then the menstrual irregularity is the main concern. And then, of course, the reproductive concerns with an anti-androgen in young women, we need to keep these two in mind. When you give spironolactone alone, okay?
Yes.
So I think over to our rapporteurs for closing and opening the second case.
So I would like to conclude the first case. So the valuable takeaways for this case are AMH is not recommended in every suspected case of polycystic ovarian syndrome, and it is required only to rule out if you are suspecting premature ovarian insufficiency. Ultrasonography is not routinely required in patients with polycystic ovarian syndrome, and it's important only when we are suspecting endometriosis or uterine adenomyosis, or in patients with single diagnostic criteria to confirm the diagnosis of polycystic ovarian syndrome. Weight loss in severe and super obese individuals with PCOS would be better with bariatric surgery. Over to Dr. Bharti. Thank you, sir and Mark. Special thanks to Tejal for the insightful concepts regarding the PCOS. And I would like to invite Dr. Rajesh, sir. Next case.
Yeah. Can I share my screen? Can I share my screen?
Yes.
My voice is not audible.
Yeah, it's audible.
Audible. Go ahead. Yeah.
Yes, sir. Yes, sir.
I'm sharing my screen. Yeah. Is it visible? Yeah. Can I start, madam?
Yeah, please, Rajesh. Please.
Yes. I'll just quickly go through the second case. Thank you for the opportunity. Endocrine Society of India and Endocrine Society of Andhra Pradesh for the excellent initiative. And let me start this case too. And it was nice discussion. I think most of the content related to PCOS is already covered, but this will be a very common case and very challenging case. I should say that considering it challenging, it's very pretty common right now with the adolescent PCOS. Let me start the case with the brief discussion. It's a 19-year-old girl preparing for MBBS aspirant, presented with the chief complaints of irregular menstrual cycles for 5 years of duration, excessive hair growth over face, abdomen for 2 years of duration, and she attained menarche at the age of 13 years with a history of oligomenorrhea, Pim's menarche, and menstrual cycle 3 to 4 days and a frequency of about 40 to 50 days, the decreased slow, and history of excessive hair growth over face, arms, legs, and abdomen for 2 years, and history of acne over the face for 3 years of duration, and no history of changing voice or balding. Regarding the birth history, she is the first child of non-consanguineous marriage, born full term with a normal with normal vaginal delivery, with a birth weight of 3 kg, no history of ICU stay, no history of any salve-based crisis, exclusive breastfed for 6 months, and milestones attained appropriately. In the family history, there is no thyroid disorders in the family, and mother had no hirsutism or there is no history of any diabetes or hypertension. No family history of any cardiovascular diseases or fertility of neonatal deaths. And she had a history of, as you can say, she is preparing for MBBS entrance exam, and she has a history of Talmud, lack of interest in previously pleasurable activities, lack of concentration on studies, and decreased social interaction in the last 1 year. Regarding the dietary history, she reveals dietary intake of about 1,800 to 2,200 kilocalories per day, and typically she takes junk food and a sedentary lifestyle since last 1.5 years. With this brief history, what are the definitions of a regular menstrual cycle in an adolescent across the different age groups? Madam, any? Hello?
Yeah, Rajesh, please proceed.
Yes, madam. So let us directly see to this. There is an adolescent case with a PCOS symptom. You can see that the definition of regular menstrual cycles in adolescents is different from the adults. It is defined that they, as a irregular cycles are pretty much common in the early part of the post-gestation years after menarche. It is defined that the first 2 years after menarche, post-menarche, the irregular menstruations are normal and it has to be ignored. And we should not define PCOD based on that. And post 1 year to 3 years of post-menarche, less than 21 days or 45 days to be considered as oligomenorrhea. Post 3 years menarche, less than 21 and more than 35 days, or you can conclude that less than 6-8 cycles per year to be considered as oligomenorrhea. As if we discuss another case, more than 90 days post 1 year post menarche in any cycle to be considered as a oligomenorrhea and to be evaluated. And one more thing to be noted down is that the primary amenorrhea bias 15 years, more than 3 years post telarchy, after attaining is about 4 to 5, should consider as a PCOS. Can you please throw some light on this, madam?
In your case, definitely it is. She has an ovulatory cycle. Certainly, she's 3 years post menarche in this case. I think 6 years.
Yes.
And then, of course, it is abnormal in the presence of a hyperandrogenism. Yeah.
So
Please
going to the
go back.
examination. So vitals, it will beats 1 minute. BP is normal with height of about 158 centimeters, weight of 54 kgs, BMI of 21.6 kg per meter square. A normal BMI with a cancellation of grade 1 and modified FG score of 13, which is really about mild grade of Hirsutism, and no goiter, no temporal hair recession, and SMR of A plus, B5 and B5. Systemic examination is unremarkable. At the end of the summary and history examination, I can conclude that a 19-year-old adolescent female presenting with oligomenorrhea suggesting of anovulator cycles and mild hirsutism. There is no significant family history of menstrual irregularities and hirsutism or early deaths. No features of virilization are noted in the examination. And you can see that the differential diagnosis in this case would be about hypothyroidism, anemia, non-classical CAH, or hypothalamic amenorrhea considering health history. Regarding the case investigations, hormone evaluation, NH is about 10 and FSH about 6. Done in the total testosterone level 70 ng/dl, little higher. Levels and serum prolactin of 21 ng/ml, normal levels, and 17 OHP of 1.4, which is normal, done in the day 2 post-withdrawal bleed, and DHS level of 360, TSH level of 3 points. Any comments in this slide, ma'am?
So this particular case is a normal BMI, 19-year-old female with hyperandrogenism, again, clinically as well as biochemically. So other investigations, there is exclusion of prolactinemia, there is exclusion of hypothyroidism, and of course, adrenal androgen excess. So probably this is again a case of a normal BMI and then PCOS confirmed. So the only concern in this is she's an adolescent. Of course, definitely she has satisfied the criteria for diagnosis of PCOS.
Yeah.
Tejal, you would like to add?
Madam.
Yeah, I agree. Just a 17 OHP is slightly on the higher side. I think Dr. Rajesh has put it there just to make things more interesting. But yeah, if there was a family history of consanguinity, any cousins who are short and dark, anything like that, then I would consider an ACTH stimulation test. But usually, I in fact presented some data on this. So usually if the testosterone values are much higher, then it is likely to be non-classic CA. Yes, I would agree with ma'am. The only point I wanted to make, Dr. Rajesh, is that labeling young adolescents with PCOS, there is no rush to do it. So though this is a 19-year-old girl, then many times 14-year-olds, 15-year-olds, 16-year-olds come to us. And if there is no emergency to label them as PCOS, because this is a cause of great distress, both to the family as well as to the girl. And I feel like maybe we need to be gentle, maybe say possible PCOS or probable PCOS, or we'll reevaluate at a later stage and then maybe come back in a few years.
Yes, ma'am.
Excellent, Dr. Tejal, your comments on there's no rush to make a diagnosis of PCOS. But how do you think this message has reached the gynecologists?
I have no answer to that. So I will share a story, Dr. Rajesh, of a young 14-year-old girl who went to a gynecologist. And at 14, she was told that you have PCOS and you have a bad lifestyle. And that is why you have developed PCOS. This girl sees me 10 years later and has now developed bulimia and mixed anorexia bulimia because she was so stigmatized by the fact that somebody told her at 14 that you are responsible for your PCOS and you should lose weight. Otherwise, you will destroy your health. And such hard words were used that it stigmatized the girl for the rest of her life. Yes, I don't know. We can't change other people. Maybe we just start with ourselves.
Yeah.
Thank you.
One more caveat on 17 of HP based on the recent guidelines that if the level falls in between 2 to 10, we do spacity stimulation test and check for 17 HP.
Correct.
What the new guidelines is saying that cases like this, when we suspect about non-classical CAH or other types of CAH, it is better to go for steroid profiling is what the new guidelines is saying. So
Okay.
rather than going for a 17 HP.
Yeah.
So what are the issues with the reliability of hyperandrogenemia in adults and how does it impact the diagnosis? Michael, madam?
See, again, this is a big topic by itself. So we do total testosterone. Then, of course, more reliable is the bioavailable testosterone. And then we also added DHEAs. These are the three tests that are usually done to diagnose hyperandrogenemia in adolescents. But then, of course, the assays again, the way the tests are done, and then, of course, the cutoffs, all these are issues that need to be tackled with. So definitely, it does impact the diagnosis. I think a bioavailable testosterone, especially if the woman is obese, I think that is a better option. Tejal, your comments?
So I would not really bother much about the blood investigation because she has clear-cut hirsutism. I would not really be worried about the biochemical androgen estimation slightly because if we have clear-cut oligomenorrhea with hyperandrogenism, which is clinical, and we've ruled out other possible causes of PCOS, then I would not really, in fact, go too much into this. But agree with ma'am that there are challenges to testosterone estimation. We all face them in the clinic. And yeah, maybe a calculated or bioavailable testosterone would be a good option.
So let us see some of the points which we can go through regarding this topic. One important thing that we can understand is that mild acne are quite common in the adolescents and it may be transient, may not reflect the hyperandrogenemia. And acne alone without hirsutism is a weak predictor and only moderate to severe acne, which is not responsive to the topical treatments is considered to be. But still they are not in the diagnostic criteria. Just it warrants the doctor that we have to check for the hyperandrogenemia in the blood test. And one more thing, the testosterone levels rise during the anovulatory cycles. That can also be one of the confounding factors. The high testosterone levels giving the wrong notion that the levels of testosterone during the anovulatory cycles. Regarding the other metabolic evaluation, the fasting plasma glucose of 90 mg per dl, 2 hours post 75 grams, it is about 134 mg per dl. Total cholesterol 181, HDL of 42, LDL of 62, triglycerides of 164, and SGOT SGPT of 25 and 28. Any comments on this section? Regarding the
Please proceed, Rajesh. All these look normal. Please proceed.
Regarding the case to imaging, actually imaging is done outside. Just to give a importance of about right ovary, you can see that number of follicles are more than 20 follicles in the left ovary, more than 20 follicles. The impression is that the bilateral polycystic ovaries based on adolescent PCOS criteria. The importance of keeping imaging here is that in adolescent, as per the new guidelines, it is not considered as a factor to decide for the PCOS diagnosis. So what is the comments on this, madam? Why is it PCOS morphology used for diagnosing adolescent?
PCOS morphology is again confused with the multicystic ovaries, multifollicular cysts that are present in an adolescent ovary. And that is the reason why we do not do a PCOM till 8 years post the gynecological age. So this is the main concern.
Yes.
So this particular case is your case is 6 years post.
6 years post menopause.
Okay, but then of course she has satisfied the criteria. Tejan, your comments?
Yes, ma'am. They,
Yeah, again, in this
what,
case, with
they,
hirsutism and oligomenorrhea, USG will be something that is not of importance, and I would not even do an ultrasound. But unfortunately, most of them come with that ultrasound report, so there is not much, like ma'am said, that we can change our practice, but we cannot change other people's practice. But yeah, and most important thing I want to point out here is the familiarity of the radiologist with the criteria and doing a proper ultrasound. So you will see so many ultrasounds with such poorly written reports. There's not even an ovarian volume which is written there. They just write polycystic appearance and let it go. So I think that sonography is like a minefield where a proper radiologist done 8 years post-menarche, done carefully. If we could get like the follicular number per ovary and all of that, then it's truly helpful. And I think very rarely we need to do a sonography to make the diagnosis of PCOS.
yes, ma'am. Valid point. And one more thing is that gonadotropin stimulation is also one of the reasons that the polycystic features.
Yes.
Apart from that, even the volume, increase in the volume of the ovary that is actually satisfying the adult criteria is also pretty common in the gynecological years. So
Correct.
And the probes also, I think, cannot use transvaginal in the adults and girls. That is one of the important things which is not a reliable indicator for diagnosis.
I think
So
that
what are
is
the
the
challenges
reason,
in
Rajesh.
diagnosing PCOS in?
Yeah, that is the reason, Dr. Tejan, don't rush for a diagnosis of PCOS in an adolescent. So that is the message. That's all. Yeah.
And also, if there are obese girls, then again, doing the sonography also is technically challenging for young girls. So then again, yeah, there is no rush to make diagnosis.
So what are in general, what are the challenges in diagnosing PCOS in adolescents?
Everything overlaps.
Yes.
Adolescents do have anovulatory cycles. They do have acne. Then maybe
Yes.
mild hirsutism. Then all these, there is a huge overlap. And again, the same thing. Let us go with what
Yes.
Dr. Tejal mentioned, no rush in diagnosis. Yeah.
So, and just go through the take-home message. The ultrasound and active measuring hormones are not recommended in the adolescent criteria. In adolescent, we have only 2 of 2. I think we can simply take home message is that the strict NIH criteria can be considered as an adolescent criteria straight away. This, as the Rotterdam criteria came up, as it introduced the ultrasound in the criteria, the incidence of PCOS went up. And as the and post the advent of diabetes and lifestyle changes, then radiology scans have much more increased the overdiagnosis of adolescents. So I think we can simply keep in mind that the strict NIH criteria, the initial NIH criteria, is almost equivalent to adolescents PCOS criteria. What is your take on this, Madam Tejal, madam?
I'm sorry, what did you say? The last sentence? I heard everything except the last sentence because somebody was speaking in the middle. Sorry.
Yeah, I'm saying that I think we can simply keep in mind that the strict NIH criteria, initial NIH criteria, which didn't include the ultrasound in its criteria, that can be simply an application of adolescent PCOS criteria.
Absolutely. I'm all for that. And I think just that as endocrinologists, what I would encourage is when you do talks among gynecologists in your area, then you bring up this repeatedly in your talk. So I have a very good connect with the gynecologist in my area. So whenever I get the opportunity to give a talk, I keep reiterating that adolescent PCOS, don't rush for the diagnosis, don't rush to label, don't tell everybody that lose weight and everything will be fine. And there are these certain standard sentences which we communicate to people. You put this one slide, Dr. Rajesh, on the challenges with adolescent PCOS. I think the biggest challenge is that these are young women who are not really fully emotionally mature. They, as of yet, do not understand the importance of the lifestyle modifications. There's a lot of conflict between the parents and the adolescent girl. So I think it's a very critical time of a woman's life, and we all need to just handle it with a lot of sensitivity.
And I think it is right time for us to start rating diagnosis, right? Risk for PCOS rather than simply treating PCOS.
Correct.
Yes. So the final diagnosis is primary PCOS phenotype with mild depression considering a past history of symptoms of depression. And what is the lean PCOS and how it is different from obesity associated PCOS?
So this
Again,
girl
it's
has this girl has a normal BMI. Her BMI is 21, right, Rajesh?
yes, madam. 21.6.
Yeah.
Yes, madam.
Yeah. So a normal BMI, PCOS. Definitely, even these, what studies have shown is that even these women do have a higher, if you look at their waist circumference, they do have a higher waist circumference. And then they do have insulin resistance, which is again, that is one way so there seem like obesity associated PCOS. But however, the important thing is the clinical manifestations are slightly different in normal BMI and PCOS compared to obesity. They do have more of, I think, cycles and less of androgen excess. And this is actually more common in our Asian population, Indian population. I think even normal BMI, they do have this. Dr. Tejal, over to you.
Sorry, extremely sorry. The question was,
Lean
Lean
PCOS and
PCOS
how is
versus
it different?
obese necessary.
yeah, it's just, I think the biggest frustration point in lean PCOS is we can't give them lifestyle modification as an option. I think that's the biggest challenge. But in spite of that, many times it happens that the lean PCOS is also advised to lose weight. And the mother will say, but madam, मैं कहाँ से इसका वजन कम करूं? Because she's already so lean. So this is where we need to think a little differently, that it's not only insulin resistance, but a lot of other pathophysiologic ways in which a young girl can develop PCOS. But as you said very rightly, weight maintenance can be the focus. Regular physical activity with muscle strengthening can definitely help. A low carb, high protein, high fiber diet can definitely help. So weight loss does not need to be the prescription, but weight maintenance is the prescription. Metformin may not be very useful in this situation as compared to the other more overweight or obese PCOS.
Did you try pioglitazone in these sort of women? Did you try?
So when I was at Nair, my head of department, my professor, at that time there was some study going on rosiglitazone, and unfortunately then because the whole thing came, but one of my colleagues actually did a study on use of insulin sensitizers like pioglitazone and rosiglitazone in young lean women with PCOS, and they did have good results. Somehow it's unfortunate that it's nowhere in the guidelines, and especially for a country like India where GLP-1 analog is not possible to give everybody, or it's a good drug, but unfortunately it's not in any guidelines. Maybe we need to come up, the ESI needs to come up with Indian guidelines for PCOS.
It's one more important thing which is often missed in our practice, addressing the mental health in PCOS. I think, Maitli madam, can you please throw some light on this?
This is Dr. Tejal's area of interest, and then we will ask her to talk about mental health and PCOS. Yeah.
I think it's the most neglected part of PCOS. We forget that the young girls who already have a lot of issues with how they feel about themselves, they experience a lot of poor body image, lot of weight stigma, lot of anxiety, lot of depression. We published a paper where we compared these emotional and psychosexual well-being between women in Birmingham and women in India. And we also, in Birmingham, they looked at the Caucasian population and the Asian Indians as well. So this is a problem. Up to 25 to 30 percent of all women with PCOS have some or the other impact on mental health. One other area which is very poorly studied is the sexual function as well, because they feel very masculine. They don't feel feminine enough. They internalize a lot of the body image and the weight stigma. So profound mental health impact. In our clinic, what we can start with is just asking a few simple questions. How are you doing with the PCOS? How are you coping with the PCOS? How does it make you feel? How is your mood? Are you really generally able to enjoy your life? Or how does this impact your quality of life? So you may not have a questionnaire for every single person. There are many women with PCOS who are very well adjusted to PCOS. They do not have anxiety, depression, like 70% will not. But that 30% of women, we do need to ask a couple of questions to know what their mental health is like. The other need gap is, even if the woman is having some mental health struggles, we usually try to counsel the patient ourselves, thinking that we can fix the problem. But counseling is not what we are trained to do as endocrinologists. So taking the help of psychologists, taking the help of somebody who is trained to do this and helping them figure out their mental health is extremely important. Some PCOS women may also have suicide intentions, may have intention to self-harm, at which time you may also need to enroll the help of a psychiatrist to help them.
I think the adolescent girls, the biggest challenge is education system, which is very competitive. And I do think we have to counsel the parents also to at least provide them some time, because the moment we say them to lose weight or you do something physical activity, they say that the child is going 7 a.m. in the morning and 7 p.m. in the evening, she's coming back. When is the time for her to do exercise? So I think it's better to discuss with the patients and also the parents and see to that what is practically feasible for her, and also discuss with some school authorities or college authorities how it can be challenged. Yes, madam. I think the session is over. In this case, madam, what would you suggest the treatment for this patient?
So her
Are you on-
concerns are
Sejal, madam.
same, no? Her
Madam,
same.
go ahead.
Yeah. So she has two concerns, Rajesh, right? So
Yes,
number
madam.
one is, of course, mental health, I think, should take a priority in this case. And then secondly, she has irregular menstrual cycles, and then she has hirsutism. Again, like the previous case, what Dr. Tejal mentioned is talk to her about how concerned is she about her hirsutism. And if she's really concerned, I think start with the spironolactone and hormonal therapy. If she's willing, I think we need to have a patient-centric approach in this particular case.
Yeah. Rightly said, madam. I think
Want to
it's
add
very
something?
important.
No, ma'am, you're absolutely right. Addressing the hirsutism is the first step, because as she starts to look better and feel better, then this, of course, will help mental health. And side by side, if there is significant amount of anxiety, depression, then taking the help of a psychologist or a psychiatrist.
Yes, madam. I think the end of this.
I think the session is now open for questions from the floor. So we would request suggestions, comments, questions.
Madam, what would you suggest? 20 or 30 for adolescent? In case you want to give OC pills, what dose of estrogen would you suggest? 20 or 30?
What did you mean, Rajesh? What is 20, 30?
Oh, estrogen dose, madam. Low dose of estrogen or the high dose of estrogen? 30. 20 mcg versus 30 mcg. Because there is a different school of thought that higher the doses of estrogen to be advised to.
I am a little concerned about a higher dose of estrogen. I would start with 20. There are some questions. Can we use oral semaglutide for weight loss in PCOS? This is Ram Mohan is asking this question. I have never used it, Ram Mohan. Maybe we will ask Dr. Tej in her comments. Oral semaglutide for weight loss.
So it's off label, so I don't know if it's politically correct to answer, but yes, I have used with excellent results. But of course, financial constraints are there. Not everybody can afford it. But yes, in women who can afford it, I get a lot of dentists, physiotherapists who afford the medication. And yes, I have used them. Dr. Sharmil Gadve from Maharashtra also has some data on the use of semaglutide in PCOS and improvement in the androgen profile and the weight loss. So yes, I do use it, Dr. Ramon.
Do you tell it to the patient before itself, ma'am, that it is off label, I'm not supposed to prescribe, but still you prescribe? No, or you don't mention it to the patient?
It didn't occur to me that I should mention it to the patient. But yeah, I'm okay with mentioning it as well. I think as long as you have a good doctor-patient relationship and there is trust and you are very clear about all the pros and cons of the medication, usually there isn't a problem. I will keep that in mind, Dr. Kavya, in future.
No, I just wanted to know because when they land up in any of these adverse effects,
And they'll
they study all that from Google, come back to us and say all these.
Has that happened to
No.
you?
I haven't prescribed yet.
So, okay.
So Rajesh, that happened to you? Yeah, so hasn't happened to me yet.
No,
but thank you very much. Pardon?
It happened to me once, madam.
Yeah, so I will also be more careful in future.
Because it's normal for the normal dapagliflozin and other drugs which we prescribe for diabetes management also. If you are not telling it earlier and they just land up in simple adverse effects, they come back with lot of knowledge from Google and bombard us. So I'm not really like in favor of starting, because many patients have come and asked that there is a drug come up for weight loss, not without diabetes also they are using it seems. Can you start us?
Okay, so maybe I'm a bit adventurous, but yes, the only thing is, yes, adverse effects, I will tell them everything. I tell them full disclosure, when you stop the drug, the weight will come back. It's not going to fix the problem. You need to continue diet, exercise. So all of that, yes, I definitely disclose. But the fact that it is not approved, it didn't occur to me. So I will be careful about that.
So I think, are we done, Kavya? Are we going to close the session?
And there is one more question. What is the best management strategy for managing lean PCOS? That's by Dr. Sidhu.
I think this has been shown in a very good slide, Situ. So weight maintenance is what we have heard from our
The
Yeah,
slide has
it
been
was-
shown.
and also we did discuss about the usage of pioglitazolides.
So I think there are no questions now. I would ask Dr. Bharati to end the session by giving her vote of thanks. Thank you, madam. As we come to the conclusion of this enriching and insightful webinar, it's my honor to deliver a vote of thanks. First and foremost, I would like to extend our deepest gratitude to our guest of honor, Dr. Narendra Kotwal sir and Dr. KVS Harikumar sir. We are honored to have you with us today, sir. A special thanks to speakers, Dr. M.V. Shekhar Reddy sir and Dr. R. Rajesh Moganty sir, for the time and effort you have put in delivering an engaging presentation. A sincere thank you to our esteemed panelists, Dr. Maithili Madam and Dr. Tejal Natya Madam. Your expert contribution have truly enriched our understanding. We are grateful for your time and knowledge. A special mention to Endocrine Society of India and Endocrine Society of Andhra Pradesh for taking such an initiative and helping us for understanding and enriching our knowledge. Our extended gratitude to all the participants who have joined us, organizing team, volunteers, and technical team whose hard work have ensured smooth running of this event. Thank you to everyone who made this event possible. We look forward to seeing you at future events. Good night.
Yeah, thank you so much.
Bye, everyone. Thank you.
Thank you. Madam, next webinar is on February 19th, madam.
Special thanks to Dr. Tejal. Right?
Yes, thank you so much, madam.
Thank you.
Thanks, Ramon,
Thank you.
and thanks, Dr. Maithili. Great cases, both of you. And thank you, Dr. Kavya and Bharti. Good night.
Good night.
Thank you, madam.
Bye.
Thank you, everyone. Thank you, Raman. Thank you, Maithili, madam. Thank you, Tejal,
Bye.
madam.
Thanks a lot.
Thank you, madam.
Thank you.
Thank you.
Bye.
Thank you.